Thank you very much for having me here today. I'm incredibly grateful for the funding and the opportunity to do this research that I'm really very keen on. Now, I live and work on research on Whadjuk land, Fremantle, Rockingham and Murdoch. And I just want to say to you, we've got a fantastic healthcare system in WA, but our healthcare system's under stress. And that's leading to crowding in emergency departments and outpatient departments in hospitals. And what we need to do is we need to find solutions which maintain the quality of care but that are resource efficient, right? And then the other thing we need to keep a focus on is that people are at the heart of healthcare. And to sort of exemplify this, we went and did a World Cafe with the people of Rockingham and asked them what they needed when they came to get healthcare with an injury. They gave us really clear messages. The messages were, we need easy, flexible access to care. We need clear communication from clinicians and between clinicians. We need you to meet our expectations of care and the needs that we have in care seeking. And we need you to meet us when we're injured and help us all the way through to recovery. So these messages ring throughout the research project that we're going to do. And so our goal is to find efficient and equitable ways to provide care to a particular cohort of people with simple self-limiting fractures, to provide excellent patient experience and to optimise the patient recovery. Now, if you're not a fracture nerd, I am a fracture nerd. You may not know that some fractures are simple and self-limiting. This fracture on the screen is one of those. And if you experience this fracture, it is stable. You can walk on it. You can move straight away with this injury. And in fact, immobilising you is harmful. They have fantastic healing capacity. And there's a large number of this fracture type. And what they need is time and good information. Now, for 160 years, the gold standard of fracture care has been an in-person appointment with an orthopaedic doctor, and then a cycle of appointments to take people through to recovery with x-rays that go with it. This is fantastic care, but it may represent excessive burden and expensive care for people who've got simple self-limiting fractures. So it should be no surprise that in Glasgow, the Scottish are quite pragmatic, they invented a virtual fracture clinic. And what happens there is people with simple self-limiting fractures are identified, and rather than coming into the hospital, they are communicated to by telehealth. In 2020, we launched one of these clinics. I helped set it up at Fiona Stanley Hospital, and it has been shown to be considerably better for the hospital in terms of cost and footfall in the hospital. A third model of care, which we're going to investigate, came to light in Amsterdam in 2019. And in this model of care, the agreed simple stable fractures are identified at the point of care in the ED. A mobile phone application is provided to patients and they don't get any further referral. But there is a safety net. And the first safety net is that we do an x-ray check. The orthopaedic doctors do an x-ray check to make sure we've got it right. But then after that, if we've got it right, they manage themselves. But a key principle of virtual fracture care is that they're able to reconnect to the hospital at any time to receive more care if they need it. So we're going to bring the Dutch model to Rockingham Hospital in 2026, and their app's on the right-hand side here. And this research has been driven by a really important group of consumers, one of whom is sitting right here at the table. Hi, Jane. Thank you very much for your support. I think Judith would love to be here too, wouldn't she? But her daughter wouldn't let her drive. And what we're going to do is we're going to take a consumer-led program of research to investigate this Dutch model. So we have a world-unique opportunity to compare standard care to our virtual fracture clinic at Fiona Stanley, to the new clinic at Rockingham, the new process. We want to make sure that the results that they achieved in Holland, where it started in one hospital but is now ubiquitous to all hospitals in Holland, we want to make sure we get the same health services results, the same patient outcomes. We want to do cost effectiveness and see if we can replicate their results in Perth. One thing that hasn't been done yet is we haven't done any research to understand the patient experience of receiving virtual care. So with the money from this fellowship, we're going to do that in the next 3 years. And this is also important for the hospital because it gives quality assurance to this process so we know that we're doing the right thing for our patients. And finally, I think Elizabeth, you and I might be friends in this process. We're going to try to adapt a model of care for people for whom even going to the hospital is too much. and see if we can find a way to increase access to care for the vulnerable members of our community in a co-design process. So I'm hoping we're going to reduce the cost of care, maintain the quality patient experience, make sure we get good outcomes, increase equity, and identify a model that might be actually viable at every hospital in Australia. I want to thank the RAIN Foundation and the FHRI Fund for this opportunity. This will transform my life because it means I can focus on the research. My family are going to be around a lot more because I'm actually having funded research. We're incredibly grateful. My wife over there is incredibly grateful. And I also want to acknowledge these incredible people who are involved in making this research possible. So thank you very much.